I know, Corey, you brought up the issue about concurrent versus sequential testing. And if the patient is symptomatic and they have stage 4 disease, I think our thinking is evolving. Because if you test first for EGFR mutation and then wait to see if that comes back, and then test for ALK, et cetera, of course, a lot of time can go by. So how do you decide on an individual patient, you know, how you're going to test concurrently or sequentially?
Again, we'll do it routinely concurrently for the for the most important 3, at least the EGFR and EML4 ALK. The big issue is the timing. We ideally like to get these results within a working week or 2. If a patient's very ill, the tests are not yet back, they're highly symptomatic, their performance status is declining, that individual will start on chemotherapy. We don't really have the luxury of that sort of wait. The big dilemma, of course, comes up. They've received a cycle or 2, their disease is stabilized or improved, EGFR mutation comes back positive. Should we switch at that point, or should we see them through the course of chemotherapy and then perhaps use erlotinib as a maintenance approach, or perhaps integrate it later on in the second-line setting? I don't think we have a firm grip on the optimal
What would
strategy.
you do?
If they're doing well on the chemotherapy, I will actually maintain the chemotherapy for 4 to 6 cycles and then go on to maintenance. Depending on the nature of their response, how symptomatic they were, how well they're tolerating the chemotherapy, I will either continue some sort of maintenance, either switch or continuation maintenance, or if they've had a tough time with the chemotherapy, I'll then go on to erlotinib maintenance. Certainly the Saturn trial showed a major progression-free survival advantage for erlotinib in the maintenance setting in the EGFR mutant patients. I think the hazard ratio is down around 0.1, which is really one of the most striking results I've ever seen.
Yeah, we don't have many of those hazard ratios.
Literature. So, but it's a big dilemma. It's a better dilemma to have than we had in the past.
Yeah, I would echo. I think an important point, I am a firm believer that you complete the chemotherapy evaluation at least the 2 cycles, because the response rate for an EGFR for erlotinib in that setting with mutations, maybe 70% response rate or whatnot. But if you get 2 cycles and they respond, that's 100% for that patient. So and you know, prognostically they do better with chemotherapy having the mutation and not. So I get those 2 cycles in, and then if they're doing well, continue as I would without knowing, and then make that same assessment. Right. Probably use it as maintenance.
It's intriguing. If you go back to the Roselle data and you look at survival in the setting of EGFR mutation, whether it was used first or second line, the survival is essentially
exactly.
Yeah, no, and I think part of the art of managing advanced non-small cell lung cancer now is not abandoning therapies that are working too soon. And it would be very nice if a patient has a very nice symptomatic radiographic response. I would have no problem continuing the chemotherapy with some form of maintenance, and then because of the Roselle data, you have a very good second-line treatment for that particular patient. So I don't think it necessarily mandates you switch to erlotinib based on that. Remember, erlotinib is a convenient drug, but it can be it has its toxicities.
It'll be quite toxic.
Yeah,
I saw a patient back just yesterday who had a grade 3 rash. He's thrilled because his disease is essentially in complete remission, but to be frank, he's had a bit more toxicity on erlotinib than he had on prior chemotherapy.
I tend to err for the deletion exon 19 because we know that those patients probably are a little bit more sensitive to the EGFR TKIs. If I get that back, I am more likely to push to get them onto an EGFR TKI. You know, the ones who have the rare EGFR mutations, or sometimes L858, I will ride them out with the chemo for the 4 cycles of therapy, 4 to 6, and then switch them over to maintenance erlotinib.
I haven't really made distinctions based on the nature of at least the 2 actionable mutations, the 2 activating mutations, 19 and 21.
Yeah, I might feel exactly the opposite, Ann. I might feel if you have an exon 19 and you know they're quite sensitive, then to ride out the chemotherapy or maintenance therapy, whether it includes bevacizumab or not, and then think about the use knowing that they're going to be quite sensitive. So, you know, I don't think we have consensus on this point.
I think a lot of the questions that we're raising today, we have an expert panel, but in reality, there are no right or wrong answers. And I think that's the value for this educational series, is we get to have different opinions. I'll throw in my own 2 cents, is that our published data suggests that patients with EGFR mutations have very low DNA repair. and in fact that they should respond better to platinum-based chemotherapy. It mimics the data also from Mass General. And interestingly, looking at ERCC1, it is the exon 19 deletion tumors which are most sensitive to chemotherapy, have the lowest ERCC1. So those are the patients, actually, I feel comfortable about finishing up the chemotherapy, but there's no right or wrong answer here.